Welcome to Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our goal is to provide a platform where we can educate, advocate, and inspire women leaders to lift as they rise. With every episode, you'll hear from her as we showcase the perspectives, insights, and experiences of women who are leading the way in advancing women's health and empowering the next generation of women in healthcare.
Welcome to today's episode in Season 2 of our Women in Healthcare Leadership Series, which I'm delighted to say has recently been honoured with a gold at the 2024 AVA Digital Awards. My name's Victoria Harvey-Jones and I'm Associate Director of Clinical Strategy at Medscape Oncology Global. And I'm delighted and honoured today to be joined by two incredible women. Dr. Ophira Ginsberg, a medical oncologist and global women's health researcher with nearly 20 years of experience in global cancer prevention and control. In 2022, she joined the US National Institutes of Health as a senior advisor for clinical research at the National Cancer Institute Center for Global Health. Welcome, Ophira.
Thank you so much.
Also with us is Dr. Werner van der Pooij, a senior consultant with over 25 years' experience working at the National Center for Radiotherapy, Oncology and Nuclear Medicine Department of the Kolibu Teaching Hospital in Accra, Ghana. Werner is also adjunct professor in the Department of Oncology at Queen's University in Kingston, Canada. Now, she describes herself as a unique breed of clinical oncologist, and I'm very excited to explore that more. Welcome, Werner.
Thank you so much.
So today we're going to explore the report, Women, Power and Cancer, a Lancet Commission, that was published at the end of September last year. We're going to talk about why the commission was set up, who is involved, what are the key findings, and of course some priority actions that really need to be addressed. And if you're not familiar with this, then I encourage you to take a look via the link in the show notes. So let's get started. Ophira, Werner, please can you give our listeners some background to yourselves and your path to becoming a female leader in your field today? Ophira, perhaps we could start with you, please.
I guess when I think about what led me to become a leader, it harkens back to some really good advice that I received as I was finishing my medical oncology training at the University of Toronto. Someone suggested to me, actually a global health leader in his own right in France when I was in Vietnam the first time, and I was engaging with a handful of experts trying to advise throughout Southeast Asia on cancer control. And he said, you know what, in your first job, when you negotiate, you should think about an area that really distinguishes you, something that is special. What do you have that no one else has? And see if you can leverage that into even a leadership opportunity, regardless of it being your first academic oncology role. And I thought, that sounds crazy, but what a great idea. And then I considered the fact that I was a genetic counselor and I'd been working in the field of clinical cancer genetics for several years prior to medical school. So I was able to leverage that into becoming the director of a clinical cancer genetics program right from the get-go in my first job at Queen's University in Kingston, Canada. And so that helped me emerge as a leader even early on, even before I knew I could do it. You know, it's acting as if you can. Yeah.
I love that story. Thank you, Ophira. And I know that that's going to really, it's certainly resonating with myself, and I'm sure it really is with our listeners as well. So thanks so much for sharing that. Werner, over to you, please.
Yes, thank you so much. You know, I got a scholarship to do my training in the United States, and there I met a lot of stalwarts in oncology, and I just admired, most of them were women, admired the way they commanded the audience, they knew their stuff, they related on the global stage, and I thought, well, I could do that, and I was encouraged by these same stalwarts to volunteer, you know, in a lot of positions, and I thought that really helped me, and I do the same with my mentees now. Because with then people see what you say, they see they read your stuff and they realize your competence and what you can bring to, you know, the global forum in terms of cancer care. So I would say that I met Ophira that way, again, on the global stage. And that's how we started connecting and collaborating with so many other things. And I just realized I can harness on the fact that I live in Africa. A lot of people think they know a lot about cancer in Africa, but then I consider myself an expert because I have the international, I'll say, subcontinental expertise in Africa by knowing what most people do in different countries, knowing most of my colleagues by first name, and we tend to discuss, a lot. So I think that's how I became a leader, in Africa, especially with my mentorship duties, making sure that everybody is up to par with what they're supposed to know about cancer to improve outcomes on the continent. And I think the best thing is knowing that you can do whatever you do, you can do wherever you are, to promote leadership among other women as well, and other men, of course, but women most of all, because we have so many hurdles. And I've made it this far, and I hold the hand of other people to do that as well. Thank you.
Oh, wonderful, Werner. I told everyone listening I had two very inspiring women on the show to us today, and now I am really, really excited to get stuck into let's talking about the commission. So, Afira, if you could sort of start us off, please, by talking us through what led to the development of the commission, and why, from your perspective, is it so important, and what's its mission?
The commission actually, the origins of the commission date back to a 3-part series of articles in the Lancet called Health, Equity, and Women's Cancers that I was privileged to have the opportunity to lead. I'd written an outline, and we gathered together 40 people from 18 countries, and we focused on just breast and cervical cancer as exemplars of cancers for which we already had adequate knowledge of how to prevent, control, in many cases, cure for women across the globe. And yet there were these huge national and, more importantly, global health disparities in these two cancers. So we drew attention to some of the social issues that prevent women from being able to access care in different settings. And this was published online in 2016, came out in 2017 in print. And the editor-in-chief of the Lancet, Richard Horton, and I had a discussion several years later. This is now right before the pandemic, actually, in London. And he asked me, how's it going? Do you feel you've made enough progress in this area? And of course, the answer is no. We're never going to be satisfied with progress, but really taking a hard look at the work, not just that we had done, but many others. I was working actually as a medical officer at the World Health Organization at the time we submitted it for publication. So I was privy to and involved in the efforts in breast cancer, but more importantly, the cervical cancer elimination project that's now a global initiative. And we really hadn't made the kind of progress we thought we should. So we took a look at the bigger determinants, right? What is really continuing to impede progress for not only women with these two kinds of cancer, but for women more broadly in terms of understanding their risks, having the agency, right, the right and the opportunity to prevent cancer from occurring in the first place, and to be able to seek and obtain quality, respectful care across the cancer continuum. And we also looked at the Women at Health Commission. That was a Lancet Commission published in 2015, led by Professor Anna Langer. And her work was really the first of its kind to look at women's interaction with the health system, both as recipients of care and as providers of care. So that led me to the idea to have a commission that was more broadly on the interaction of women and cancer with a social justice and equity lens. Yeah. So after that, I was invited to contribute a concept note, which was eventually published as a commentary with Richard Horton in July of 2020. And then I started the really fun challenge of finding terrific co-chairs, including Dr. van der Pooij, who I'm delighted to be on this podcast with, and Dr. Isabel Sorio-Mataram, who's the deputy head of cancer surveillance at the WHO's Cancer Agency in Lyon. And together we worked with 21 commissioners in total, 10 mentees, 13 advisors, and a 6-person patient advocacy committee to really hold our feet to the fire, representing 6 different countries, and from the patient advocates' perspective, what would be their priorities that we should ensure we not only cover in terms of content, but that the tone and the framing of the commission was consistent with the values of the patient advocacy community. So that's a long answer, but that's really how the commission came together. Thank you.
No, wonderful, Ophira. Thank you. And can you just really sum up what's the mission? What's the mission of the commission now that you're really set out to do?
Right. So what some people might think is that the commission was set out to write a report. And that's not the case. The report, of course, was a huge, huge effort over several years. And we're thrilled that it's come out and it's been so well received. Just was published on September 27th, 2023, with a launch event, et cetera. But that really is just the first major output of the commission. The intention is to draw attention to the global inequities that women face with respect to cancer care and control. We've named the report actually not Women and Cancer, but Women, Power, and Cancer, right? Power in three domains that we looked at in terms of decision-making, knowledge, and economics. But the point of the commission is to advance an evidence-based set of priority actions, of recommendations, which we hope and we will continue to work on taking forward into the real world. And that's aimed at a wide group of stakeholders from multilateral organizations such as the World Health Organization, national governments, as well as academia, the private sector, and civil society. And that's where we're at now. We're actually working on the next steps already. Yeah, so happy to talk about that more.
We will definitely get stuck into those. And we're the title of our podcast series, Women in Healthcare Leadership. So I guess my question is, you mentioned there about, who are the commissioners and the roles that they're coming from. And we'll talk about patient advocacy in a moment. But how many women are involved in this commission?
Right. Well, the commission, including all of the people I've mentioned, 21 commissioners plus the advisors, advocates, and mentees, is almost all women. All but 4 commissioners happen to be female. But I also want to point out the diversity, not just in terms of geography, where people are from. More than half of the commissioners are from a low or middle income country. And most of those currently working in a high income country were actually born and raised and often trained in a low and middle income country, covering the entire globe. But it's diversity also in terms of expertise in discipline. We thought it was incredibly important that, speaking of myself as a medical oncologist, what do I understand about anthropology? Very little. And I knew at least the few of us who started, myself, Verna, and Isabel, to look at, what do we not know? What do we hope to achieve with this commission that sits at the intersection of cancer, women, status of women, society, et cetera, and power. Anthropologists, social scientists, a gender scholar are among our commissioners, economists, health systems researchers. It's very, very diverse.
Oh, wonderful. And yeah, you touched about having patient advocates being involved as well. And this is something that's so close to my heart, at Medscape. I was telling you, I'm leading an initiative here as part of our education to really integrate, better champion the patient voice within our education. So, when you're saying about obviously involving patient advocates, I'd love to hear from you about, why is including the patient voice so important for the commission?
Yeah, that's such a great question. It was clear to us from the start, including among us people who have the lived experience of cancer, right? Even our editor-in-chief, Richard Horton, has been public about his own journey with melanoma. And we recognized that in order to talk about, let alone address, gender responsiveness in the healthcare system, right, to improve quality of care, absolutely requires that the patients, the people with the lived experience, are at the center, not on the periphery. They're often, we hear complaints, quite legitimate complaints, that they're added on at the end. We can say, oh, we had a patient advice. They looked at the final version of the report and made a few comments. Here, we engaged people almost from the very start. I happened to be involved prior to joining the NCI on the advisory board with a few of us for a group called Global Focus on Cancer, led by Carolyn Taylor, who's really an outspoken, incredible global advocate. And she's a networker of networks, to help advance opportunities for women and men to engage at the civil society level. So what we decided to do was to invite Carolyn, who was also, by the way, an author on that Lancet series I mentioned, Health, Equity, and Women's Cancers, that she would chair a patient advocacy committee. She could set it up however she wanted, engage with us at their request, whatever they decided, and meet as frequently or infrequently as they wanted to, et cetera. That actually led to a piece of written material within the commission on the role of patient advocates. It became clear to us that, we actually lack evidence on the value of patient advocates. These tend to be, guess what, women, largely, who are the advocates globally, with the exception of cancers that are more specific to men, and we don't want to minimize the importance of such groups as well. So yes, patients are at the heart of everything we do, and we have revealed and uncovered, like so many other aspects of the Commission research, there's a terrible lack of information that could help us also make the case for adequately funding such civil society organizations. A lot of these women are working as volunteers, and they're underpaid and unpaid, and to expect them to attend large cancer society conferences, for example, is itself a burden that many are just unable to take on.
Well, thank you so much, Afira. And again, so aligned with, what I'm championing here, and to very much to be working with the patient far earlier on, I think, than we've typically done. So making sure that we're hearing from them, informing our education, listening to them having a seat at the table, etc. And I will advocate for male advocates. I've had the pleasure of working alongside some wonderful advocates. So please, Afira.
And I'll just add, because we had patients so closely aligned, and sometimes I don't necessarily love the word patient, but people with the lived experience of cancer, they were able also to contribute in a very important way to guiding us in how we developed stories. So in the Commission report, which is a 30,000 word piece of research, a lot of empirical evidence, as well as tables and figures, and a typical research paper. We have 9 real life stories as told by women in different settings, including, by the way, thanks to one of the members of the Patient Advocacy Committee who offered her own story to sort of humanize the content and really give us more of a 360 view, not to represent any one cancer or one. We often think of women and breast cancer, for example. There's so many stories out there, but to make sure that we amplified some of the untold aspects of what women experience in real world settings, particularly the untold stories. For example, women living in refugee situations, women in humanitarian settings. And among our stories was that of a nurse. So it wasn't just people with the experience as a patient. We had a nurse in Mali, the country Mali, working with Médecins Sans Frontières, Doctors Without Borders. MSF, Doctors Without Borders, is actually one of our partner organizations. So I shouldn't forget to mention the importance of our partner agencies. Similarly, we have law and cancer as a feature in the report, as well as reflected in one of the commentaries, because the McCabe Center for Law and Cancer were among our partners, who also work with patient groups in a number of countries to use the levers of legislation as well as policy to try to drive those upstream determinants to reduce cancer risk. For example, fully implementing the international, the Framework Convention on Tobacco Control that has gender-specific actions within it that many people are not aware of. So how do we, work with our own governments to make sure that they are implementing those aspects of the Framework Convention on Tobacco Control? So I hope I didn't get too into the weeds, but just to bring in the way that patients are also involved on the policy side. It was very important to our work, as well as the storytelling dimension. We encourage everyone who's listening to this to please have a look at those 9 very moving stories. They seem tragic, but they're also stories of inspiration and resilience.
Oh, thank you so much, Afira. And you're right, patient centricity is a term that's banded around. I'm moving more and more to thinking people centricity, because it's the person who's living with the disease. And I love all of those. But look, let's move on and to talk more about the key findings of the Commission report. And then we're going to bring Werner in, who's then going to talk about the priority actions. So, Afira, if you could now get to the good stuff. So much good stuff to talk about here about the key findings of the report.
Yeah, thanks. I'm delighted to share some of our key findings. There's a lot in the report, but I'll just focus on a few of the quantitative and some of the very important qualitative findings as well. So on the quantitative side, some of these numbers may not be surprising, but we were surprised to realize that cancer actually ranks in the top 3 causes of premature mortality among women in almost all countries worldwide. Out of 185 countries, there were only 2 in which cancer did not rank in the top 3 causes of premature mortality. That's death under the age of 70 for women. Now, that's just to give you a sense of the scope of the problem. And when we dug into premature deaths from cancer, of which there were upwards of 5 million, including both sexes, we found that of the 2.3 million women who died prematurely from cancer in 2020, 1.5 million such deaths could be prevented, right? If every woman had access to what we already know regarding primary prevention and early detection. And a further 800,000 women could have been spared suffering and, importantly, premature deaths from cancer if all women diagnosed with cancer everywhere had optimal access to the best care. So those are 2 big standout data points. On the quantitative side, those are really the most important findings that leapt out for us. And if you don't actually look closely, you won't see what's there, right? This is an old sort of adage regarding what gets measured gets attention, gets reported. And so along the way, as we were preparing the Commission report, a few of us took a look at cancer under the age of 50. And I'm going to step back a moment because many people asked us, why women and cancer? Oh, you mean breast and cervical cancer? No. Why are you focusing on women when men have a higher risk of cancer? Isn't that true, Dr. Ginsburg? And I would say, yes, you are right, but, okay. So women do have a slightly lesser risk of developing, actually it's about 50-50, and slightly lower chance of dying from cancer compared with men. But when you look at women and men under the age of 50, 2/3 of the cases in 2020 occurred in women. So let's now expand. What does that mean? What does that mean for the families? What does that mean for women in the workforce, in the paid workforce, and also the unpaid workforce, which is another aspect of the Commission? People looking after relatives with cancer are often female, and they're generally underpaid, or unpaid, rather. When we looked at the women under 50, it made us think also about a parallel effort being conducted by our colleagues at IARC. Some of us were involved in this work, led by Dr. Valerie McCormack, that captured the first global estimates of children maternally orphaned due to cancer. And in 2020 alone, so think about those young women, the premature mortality, the women under 50, 2/3 of all the 3 million adults diagnosed in 2020, 2/3 were women, okay, under the age of 50. In 2020 alone, 1 million children lost their mothers to cancer. The prevalence of maternal orphans that year was 7 million children. So I really hope that number, obviously, is horrifying, but it should bring us to a point, as we've tried to do in the Commission, where we look at the power dynamics and the way in which patriarchy influences women's opportunities for cancer prevention, care, and control, and the way in which women, as generally underpaid and undervalued and often discriminated against members, right, due to gender discrimination, et cetera, in the cancer healthcare workforce also impacts on quality of care. And so it's sort of a circular phenomenon. And we brought this all together. So when I said something about the quantitative results, and I mentioned premature mortality, and then I went into adults under the age of 50 and the orphans. That's really important. So after that, and before I said whatever the next sentence is, I would just add the following. When it comes to women in leadership roles, we took a look at a few things, one of which was the number or the proportion of female editors-in-chief among the top 100 cancer research journals, according to impact factor. And we were surprised. We thought it would be maybe a third, maybe a quarter. It turned out only 16% of those top 100 cancer research journals are led by women. That was shocking. When we looked at cancer research institutes, hospitals, and other such organizations within the membership of an entity called the Union for International Cancer Control, those involved in global oncology will know well, the UICC, that's over 50 years old, based in Geneva. We took a look at the leadership in those organizations, and again, only 16% were led by women. So these are important benchmarks that we can use to track progress over time, and that speaks to what I'll mention later in terms of our next steps in monitoring and evaluating our progress and our work. Just to wrap up, because I'm not going to go through each and every data point that we presented. There's a lot in the report sort of for everyone. If you're interested in economics, we encourage you to look at that section in particular. But we tried to come up with an overarching framework of women, power, right, and cancer that kind of weaves together this story in an effective way that then points us in the direction of now what? What can we do to improve these outcomes? What can we do to ensure that data is collected, reported, and updated and made public? Because a lot of the empirical data we saw was actually hiding in plain sight, but we didn't know.
Oh, Vera, thank you. And I mean, you just set up Werner beautifully there in terms of the now what exactly. So, Werner, please, can we bring you in now to really reflect and tell us what are the priority actions now moving forward?
There were so many actions that we thought were vital. So we kind of zoned down in on 10 priority actions. They might seem a lot, but I think the scope of the problem is so huge that is the only way to make sure that we can leverage, our findings with what should happen in real life. So our priority actions, we identified 10, ensure that data collection is aggregated into sex, gender, and other socioeconomic factors, routinely collected with health statistics, and reported and regularly updated. So we are working on another project now, and when you go into the literature, you can't find anything, or it's actually very outdated, or it's only coming from some specific parts of the world. So you have a lot of data from the US, but even that is not exactly coordinated. So you have different organizations within the US reporting different data, but there's nobody that's actually collating this together. The WHO also has some data, but there's something missing. I think that we'll get more data from within the countries as well. Okay, then we also want to implement intersectional transformative strategies to increase equitable access to early detection and diagnosis. So with the cancer control plans that we develop, we just look at it both without looking at the segregation of data, because some things might be different from women than they are for men. But we tend to, not concentrating on the cancers and the preventive strategies that will improve the health of our women, like especially with preventive services and also even with the treatment, as well. So I think these are things that have to be looked up, and globally. So this is not just based individually on the countries, but also on the global stage. So we have our governance structures that need to look at this and also encourage our countries to implement this and make them, important. And that will help to plan our health strategies on how to overcome our cancers. Then we also want to do more research. We need to monitor and look at emerging cancer risks. So that was something that was highlighted. In fact, I think a few days ago, I read that some women were on strike because nobody really highlighted the side effects of hair straightness or relaxers, which tends to affect mostly Black women who like to keep our hair straight. But this data was not available. The research wasn't highlighted, but now we know, not just with hair relaxers, even with mosquito coil, something to do with my part of the world as well. This kind of data was not, bleaching creams. Nobody highlighted these. Nobody told us about this. But now we know that there are some risks associated with these things that we use every day. And I think people have to be educated and be informed to make a decision. And it actually does affect the way we manage and plan our cancer control planning, and in the end, actually increase the livelihood of our peoples. Because we need that to develop the countries economically. We always forget about the impact of cancer on the economic development of countries. So this is very important. So we need to also look at environmental factors. Smoking in women is not the traditional cigarette smoking. It's hashish, it's different types of smoking. But we all just look at the cigarette and think that's the only form of smoking. And that's where we have our actions planned. And we forget about all these things that are affecting our young women because there are no warning signs. There's no data, to show up that these are things that are important. Okay. We also need to enforce rules that, looking at our young women again, these needs to be rules that needs to be enforced, of course, backed by data. So we have the data, and I think after this commission, there's going to be more data coming out. That's going to strengthen the reasons why we need to limit exposures to our women through education. We need to co-create health systems to provide quality cancer care for women. So a lot of the women's stories that we hear, you could see that there's a lot of disrespect. There's a lot of, shunning away and ignorance of what women present with, or the possible cancers, or the impact of not being taken care of the right way. It actually affects outcomes as well, and also strengthens our health systems. So we need all this to, improve our health, the health of our countries and economies. Then, most importantly, we need to look at leadership and funding for women. There was a big splash a couple of years ago about the underfunding of women researchers in the UK. But apparently it wasn't just the UK. But when you look down into the data, you find out the same thing resonates in the United States, in Europe, and different parts of the world. So it wasn't unusual, but that is not the right way. So these are the indicators, and these are things that we need policies developed to make sure that this. So when you go back into the literature, very few countries have policies, or they are there, but they are masked under the general workforce. Not even health workforce, but just general health force. But we are talking about women and cancer, and these tend to affect the way we manage our patients. We realize that the impact of female cancer researchers actually impacted on the outcomes of their patients. So this is actually something that is very important to ensure that we have equitable resources and then leadership opportunities. You know the story, I don't have to tell you, but less than 1/3 of leaders across, from CEOs of hospitals all the way down to medical schools, to deans, to leaders, to medical oncology boards and oncology societies, academic meetings are men. So of course we can't bring up the problems that affect women, or even hone in on the problems that affect women. So you get overshadowed, and your problems typically like sexual harassment gets pushed under the table. But now we're talking because that's only just with 1/3 of women. So you can imagine if we improve the number of women in leadership. And there's enough data also to show that when women are in leadership positions, they open other avenues for other women. Women are able to multitask, and the patients actually do women better when they are being taken care of women. So there's a lot of things that can come out of this, in terms of improving the world, globally. I'll say that. Then also sexual harassment. Oh my gosh! So that is something else that was, ignored. But now we know that there's a lot of that happening, especially in oncology societies, in oncology training programs, even in our academic settings. That was hushed. And there are actually no avenues of reporting. There are no policies to protect these women. And most women actually drop out from their occupation just because of the harassment, or change their line of specialization because of the harassment that they go through. So this is one of the things that we need to develop, strengthen policies. Make sure we collect the data first of all, and then collate the data together and strengthen policies in all organizations across board, all the stakeholders, to make sure that we report this, and then these policies are enacted, in these countries and in these organizations. We need to protect our women. We need to integrate gender competency frameworks into the education and training. So I'm shy to say, I'll say this commission was an eye-opener, where a lot of things that I ignored, have come to fore, that we don't have even any training in my center for gender competencies. So this is actually something that the whole world needs to adopt. Globally, it needs to be adopted into training right down all the way, not from physicians to nurses to radiologists, everything, everybody that comes in contact, not just with the cancer patient, but generally. But I think we are honing on the cancer platform, with this commission. But I think it's an eye-opener for all of us to do something about, to make sure that we train everybody to understand the role of gender competencies in our outcomes and the way we manage ourselves as academicians and as oncologists in the global stage. And also feminist economics approach to investment case. I think Ophelia can tell you more of that. But what it is that how much do we save? What is the impact of looking at having a feminist approach to managing cancer, both right across the continuum, from screening all the way to survivorship? How much does it impact, our societies? How much does it impact our countries in terms of how much do we save, or how much can we use that money to do something else? So I think this is a very important point, that we can save so much money by impacting all of these recommendations, looking at the woman, not just because she's a woman and she does more at home, but because she contributes to the economic outlook globally. And then we can save so much money by paying attention, to the females and looking at the feminist economics approach to investment case in cancer, which is mostly ignored. And also, last but not the least, is to enforce pay standards for all cancer caregivers in a fair, equitable, and inclusive way. So, as Ophelia said, most of the caregivers, unfortunately, are women and tend to carry this burden. They leave their jobs, they leave their livelihoods to take care of chronic cancer patients. Okay, and this has a lot of impact on their social well-being and actually translates into the well-being of the society as well and the communities. So this is something that we need to make sure that it's established and implemented. There's a lot of data out there. When I looked up, there's so many things coming up, but it's not concerted. There's no concerted effort to bring this together to make sure we can come up with policies that needs to be enacted and followed up by these organizations. But this is the last but not the least, and I think this is one of the most important things that came out of the commission. There's so many other things, but I think these are the most important for now that we find.
Werner, thank you so much. I'm just sat here in awe of both of you. Just everything that Afira was saying, and in terms of the key findings and then the actions and what you're putting forward, it's just phenomenal. And honestly, truly inspiring. And thank you so much, for taking the time with us today just to talk us all through that, and just to thank you as well on behalf of all of us, the incredible things that you're doing to push forward with this. And let's just move to the final part of the conversation now. I'm getting emotional. Get yourself together, Victoria. I'd love to hear from you some personal reflections. I mean, it's so clear how passionate you both are about being involved with this, but I would love to hear from you, what has it meant to you for being part of this commission? Afira, what's it meant to you personally?
Thanks. Well, now I'm getting a little choked up thinking about it. It was a labor of love, clearly. I would say that that's one way of putting it. I actually took a bit of time out of my other roles to work, to dedicate my time to the commission. One of the most, let's say, meaningful aspects of the commission, really for me, was the relationships that I feel I've developed and also facilitated developing by bringing these remarkable people together, as I said, from different places, different academic disciplines, different backgrounds, demographics, etc., working together in such a fashion that we feel like we've become a family. It really was a community effort. And just to reflect back on some of the structural things in the commission, which doesn't sound like it's an emotional thing, but it is. Early on, as we started coming together, and remember, this was during the worst parts of the pandemic, so it was all by Zoom. We only all met together in person last year in Istanbul. once we'd already submitted the first version of the report and we're going through peer review, which was tremendously important to be in person for those few days. But coming back to the inception, we were encouraged by our feminist scholar, Dr. Shireen Haidery, who also consults with the WHO and has her own nonprofit called Gendro, and she's at the Graduate Institute of Geneva in the gender section there, to actually write out a set of guiding principles. And so everything we did was by consensus, and that was actually one of the principles itself on feminism is around collectivism, collective decision-making, and respectful engagement with each other. And so the way we governed ourselves actually was aligned with this sort of intersectional feminist approach. And we published that online on our own website really early on. I think that's been up online for at least 2 years. So looking back at the end of this phase of the commission, because we're not done yet, or this is in many ways just the beginning, but as we wrapped up the report and got that published, we were able to look back on those guiding principles with some pride, realizing that we pretty much stuck to them. I hope, Verna, you would agree that we stuck to those principles. We encourage people to read those and also to be reflective on our own experience as women and men on the commission. How much did we, let's say, give up to work on the commission? What happened in our own lives during the phases, including having to retrain or be reassigned to work on pandemic-related activities, or for some women on the commission who were single parents or effectively single parents, and that added, I want to say burden, but a joy, a pleasure, and a burden of parenting and having to find time in the wee hours even to work on the commission. So we lived it very much, and we came together as a family, and we'll continue that way.
I love that, Afira. Thank you. But Verna, over to you. What's it meant to you to be part of the commission?
Oh my God. It's like, I'll say it propelled me into another world. It's like a PhD project for me. And the fact that I learned every single day of the 3 years that with all these remarkable women, we realized the importance of the social determinants of health in the way things are construed in globally. And then the other thing is, how do we reconstruct that so it works out for women? And also, it just makes you see your weaknesses and where you could do more to improve the status of women, those diagnosed, and then your colleagues as well. And also, it's just, I guess, see things in a different light now. I have more patience because I realize that I'm not the only one going through some of these situations, or my other female colleagues, but I can give examples to other people of how to manage, and especially for women in Africa, it's tough. And I'll say as for Furia, it was very difficult to have this admitted in the African continent. It was a fight to actually even present this, and you had a lot of comments like, "Why don't you do it this way? Why is it so important?" But then you have a way of nudgingly, quietly sneaking it in that you need to rethink about this. You need to reconstruct this, and sometimes you get negative comments. But I think they're kind of like accepted because these are the same men who also have daughters. I know they're probably also going to go through things. And I think that this is actually stimulating change in our societies. And also seeing that actually it's surprising that most of the things in Africa actually were winners compared to what happened in high income in terms of the number of women on authorship. Actually Africa was actually leading, which was quite surprising. Even Muslim women were found to be leading, in terms of the leadership roles in oncology. So there were some pluses and some minuses. And that gave us a lot of encouragement to forge further and move forward with our agenda. Thank you.
Wonderful, thank you. So before we close with that, I always ask for final actions. How, just very quickly, we talked about, your personal reflections. How do you think the commission has helped others being involved?
Well, I've heard from many of the commissioners, as well as mentees and individuals, even in their advisory capacity, as having, I don't want to overstate it, but I've been told that this was a transformative experience for a number of people on a personal level and definitely on a professional level. We had a lot of sort of junior faculty members and people earlier on in their careers, and being able to not just to take part, but everyone had a great opportunity to contribute in a leadership capacity. We had individual and individual chairs of the working groups, et cetera. And everyone was offered the opportunity to also participate in dissemination activities, which continue, right? We have additional launch events coming up at a regional level, which will be chaired by people on the commission from those regions. It's not just going to be me and Verna and Isabel leading all of those initiatives. So these have been sort of, in a way, a launch pad for other work, for other collaborations, and for professional advancement, to be quite frank. Yeah.
Oh, thank you, Afira. Afira, Werner, anything else to add there before we move to close?
I'll say one of your questions was supposed to be the action for our leaders, that you can create change in your own little way wherever you are. You can effect change to make sure women get more respectful recognition and care, and you can achieve right to the highest mountain. Don't let anybody set you back. You are an achiever, and you can affect other people from your actions. Thank you very much.
Oh, I love that. Well, you've just said, the final action for our listeners. Thank you so much, Werner. And Afira, would you like anything else to add there?
Oh, I think Verna summed it up beautifully. We all need to look to our own potential role in contributing to the problem and becoming part of the solution at an individual level and also on behalf of the organizations we represent.
Well, look, wow. Thank you so much to both of you for joining me today. It really was an insightful and impactful discussion. I very much hope everyone listening has enjoyed it as much as I have. And don't forget to check out the show notes and the links to the commission to explore more. Please stay tuned for the next episode of our Women in Healthcare Leadership series. And thank you to all of you, our listeners. We really do appreciate you tuning in, and wishing you all a fantastic day wherever you are. Thank you again, Afira and Werner.
Thanks for joining us. Tune in next week as we continue our journey to amplify the voices of women leaders in pharma and medicine. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next week, remember to lift as you rise.